Lifestyle Medicine for COVID-19 and NCD Care, a wake-up call. This event is proudly supported by the Lifestyle Medicine Global Alliance, the American College of Lifestyle Medicine, the International Board of Lifestyle Medicine, the Department of Health, and the Philippine Medical Association. The Philippine College of Lifestyle Medicine is also supported by several institutions pioneering lifestyle medicine practice in the country. The Remnant Institute Incorporated, a center for lifestyle medicine and education. The Adventist Medical Center, the Four Leaf Lifestyle Medical Group Corporation, the Plated Prescriptions, and the Culinary MD. This event is also made possible through the help of our sponsors: the Pascual Pharma Corporation, the Omron, the Taisho Pharmaceutical, Simply Nature, and Foligo.
Our vision is to be distinguished as a fast-growing Filipino pharmaceutical company, advancing a legacy that provides reliable, high-quality health and wellness that are responsive and relevant to the changing needs of patients and customers. Blumea balsamifera Sambong Leaf Relief Forte. The longer, the better. Relief Forte. Relief for urinary stones. The only prescription-grade L-carnitine available today. Enhance your heart score with Carnicor. Brought to you by Pascual Pharma Corp. Building a legacy of care.
Diabetes is a chronic condition that is used to be thought of as a lifelong disease. However, fast-growing evidence shows that a patient with diabetes can achieve remission and possible reversal. This positive result is achieved through an upstream approach, which means dealing with the root cause of diabetes. There is a diverse form of landmark studies defining interventions that can result in remission or reversal of prediabetes and diabetes type 2. Every piece of evidence is pointing towards intensive therapeutic lifestyle interventions that mostly include diet and exercise prescriptions. We will have two parts of lecture on diabetes with two experts in managing diabetes patients. The first part will be discussed by Dr. Suzette Labrador. She will talk about the landmark evidence showing different types of dietary intervention, including high-protein and low-carbohydrate diets. The second part is a case presentation by Dr. Michelle Palma that will be broadcasted live during the plenary sessions. She will talk about the implementation of intensive therapeutic lifestyle intervention, with the emphasis on whole food plant-based diet, based on published clinical practice guidelines. Dr. Suzette Labrador obtained her medical degree from the West Visayas State University, and then went on to residency training at the Iloilo Mission Hospital, and further trained as an endocrinologist at the Philippine General Hospital. She is a fellow of the Philippine College of Physicians, a member of both the Philippine Medical Association and Iloilo Medical Society. She is also affiliated with the Philippine Diabetes Association, the Philippine Society of Endocrinology and Metabolism, and the Philippine Society of Occupational Medicine. She is currently the chairman of the Department of Internal Medicine at the Iloilo Mission Hospital, as well as an associate professor at the Central Philippine University, College of Medicine, and also a member of the faculty at the West Visayas State University, College of Medicine. Dr. Suzette Labrador is the immediate past president of the Philippine College of Physicians Iloilo chapter. She will be talking about lifestyle therapy, the mainstay for diabetes type 1, 1.5, and 2.
Hello, good day everyone. Thank you so much for that kind introduction. I must congratulate the officers of the Philippine College of Lifestyle Medicine for having this relevant convention. Would also like to thank Dr. Michelle Acero Palma, the president, for inviting me to talk on a topic that is close to my heart. So allow me to share my screen. So for today, we're going to look at lifestyle therapy and how it can be a mainstay to diabetes. I'm going to share my slide. I hope you can see it. So this is lifestyle therapy, the mainstay for diabetes type 1, 1.5, and type 2. So I have nothing to disclose, and my outline is clear-cut. We're going to talk about the impact of diabetes and then lifestyle medicine to diabetes type 1, 1.5, and type 2. And of course, exercise and diabetes. So what is the impact of diabetes in the world? So we can see here that everything is increasing. The incidence of diabetes is increasing such that more than the 3% of the world's population has been diagnosed with diabetes. The highest concentrations are in developed countries. This is because of industrialization. We don't use our hands anymore, so less manual labor and more sedentary lifestyle, as well as eating a high-calorie Western diet. And so if you look at all this, the percentage of population in the US, so we can see that it is increasing from 1 in every 3 people will develop diabetes because of the increasing incidence of obesity and metabolic syndrome. And also we have seen that people with diagnosed diabetes is increasing among all age groups. And they have found out that diabetes will triple, okay, from 5.5 million to 22 million. So that is for people who are diabetic. In the Philippines, we have a bitter picture. That is 1 in 14 Filipinos live with diabetes. So we have 63 million adult Filipinos, and out of this, we have 3.9 million Filipinos with diabetes. So this is from the International Diabetes Foundation. If we have a bitter picture, we also have a bitter future, and that is from year 2030, so they predict it's around 5 million plus, okay? So according to Dr. Joven Quanang, diabetes continues to be a major problem. He considers it even as an epidemic, just like COVID-19. And the prediction by year 2045, it will further increase to 7.2 million. The diabetes is on the rise. If you look at all the other countries, it is not an honorable thing to be number 5 in a country that has diabetic patients. So these are the types of diabetes. So we have type 1, this is insulin requiring. This is around 5 to 10% of the type of diabetes, and this is where the autoimmune reaction occurs, where the body attacks itself. For type 2, this is non-insulin dependent, usually adult onset, and this is 90 to 95% of the type of diabetes. So this is the most common. And then you have gestational diabetes, which is increase in sugar during pregnancy, and this will bring up increased complications in pregnancy and at delivery. And at the same time, the mother and baby will also have increased risk of becoming type 2 diabetic later on. And lastly, we have prediabetes type 1.5, so it's a pre-departure thing. This is a stage before type 2 diabetes, and so the blood glucose are higher, but not higher enough to be officially diagnosed as type 2 diabetes. So this is how you're going to diagnose. So the most common that we request is your fasting glucose, and it should be less than 100 to be normal. For diabetes, it's 126. For random, that is blood sugar anytime, it should be less than 140. For diabetes, it's 200 or higher. And for the A1C, it should be less than 5.7. For diabetes, it's 6.5% or higher. And for your oral glucose tolerance test, it's just like your random. It should be less than 140 for it to become normal. And for diabetic, it's 200 or higher. So if you would know the normal and would know the diabetic stage, then you would know the pre-diabetes. So everything else will follow. So these are the risk factors for your type 2 diabetes. So it may be genetic or it may be environment like obese and overweight, or you have a family history, or you have diabetes during pregnancy, you are hypertensive, you have a sedentary lifestyle, you are an Asian, and of course you have these other factors. So some of the factors are modifiable and some are non-modifiable. So you can modify your weight, you can modify your physical activity, but of course you cannot modify your ethnicity and your family history. So we know for a fact that diabetes destroys all the organs in the body. It can cause stroke in the brain. It can cause amputation because of neuropathy. It can cause heart attack, and it can also cause renal failure. What is important here to take note of is that diabetes can also cause blindness. And so at the same time, you also have gingivitis or inflammation and infection in your mucous membranes. So I always tell my patients that diabetes is never a mild disease. And so we move on. So what about lifestyle medicine in type 1 diabetes? So we know that type 1 diabetes has an autoimmune reaction. And we know for a fact that this is what's happening when you have type 1 diabetes. So islet function was around 80% of normal at the time of diagnosis. So when we talk of lifestyle, there's actually two parameters, your physical activity and nutrition. And this is a study where they look at the evidence for medical nutrition therapy for type 1 and type 2 diabetes. So this is looking at the evidence and nutrition practice recommendation for both type 1 and type 2. They mentioned a landmark trial, that's your DCCT research group, where it involves around 1,300 patients with type 1 diabetes. And they have this randomized controlled trial where you have a conventional therapy in one arm and intensive therapy on the other arms. And the major finding is that your intensive diabetes therapy reduced your overall risk for onset and progression of diabetic retinopathy, nephropathy, and neuropathy by 50%, which is really very significant. We have also this Irish Daphne study protocol where it looked at individual follow-up after structured education for type 1 diabetic patients. So we have this study, 2002, and there's around 136 adults with type 1 diabetes. And the intervention is that the patients were taught how to adjust their mealtime insulin based on the planned carbohydrate intake. So this is a randomized controlled trial. Or in short, your Daphne is that it means dose adjustment for normal eating. It's liking what you eat and eating what you like. So you have this structured education program for people with type 1 diabetes. So this is again a randomized, you have one arm, which is the immediate Daphne, which is the intervention, and you have the control, which is the delayed Daphne. In the immediate, there is training immediately, whereas in delayed Daphne, the training is done 6 months later. The outcome is your A1C, hypoglycemia, and the quality of life. These are the targets in your Daphne study. So the A1C is around 6 to 7%. The results show that at 6 months, your A1C is significantly better in the immediate Daphne or your intervention group, and the impact of diabetes on dietary freedom was significantly improved in the immediate Daphne or your intervention group, and the impact on overall quality of life is also improved in the intervention group. The general well-being and treatment satisfaction also improved, and there's not much severe hypoglycemia. The weight and lipids were unchanged, and there is improvement in the quality of life. It may not have reached a significance at 6 months, but it became significant by 1 year. So to conclude, if you look at skills training promoting dietary freedom, it improves quality of life and glycemic control in patients with type 1 diabetes, and without worsening severe hypoglycemia or cardiovascular risk. So that's for your Daphne study. And for your Daphne study, people have joined, and they said, looking forward to life now and not dreading it. And after the Daphne study, one said, this is a must for all diabetics. Another participant said, this week has gifted me with tools I have been missing over the years. And Another said it was fantastic. It is like a light bulb being switched on after being in the dark for the past 25 years. One participant said, before the course, I thought this is my lot in life. It is not going to get better, but the course has changed my life. So this is, we're done with Daphne's study. We look at low carbohydrate diet in type 1 diabetic patients. So this was by Nielsen et al. And this was received 2005 and published 2009. So the background is that you have 22 patients who are type 1 diabetic with up and down or fluctuating blood glucose. So the intervention was a low carb diet that's 70 to 90 grams carbohydrate per day. And then they matched the insulin dose accordingly. And then caloric requirements also were covered by an increased intake of protein and fat. So the outcome are the reduction in your fluctuation of your blood sugar. At the same time, the rate of hypoglycemia and improvement in your A1C. The results show that after 3 and 12 months, the rate of hypoglycemia significantly lowered and your A1C level significantly lowered after 3 months. The meal insulin requirements reduced and triglyceride levels significantly lowered. So that's for your low carbohydrate diet. Your total cholesterol and HDL remain unchanged. So the conclusion in this low carbohydrate diet in type 1 diabetic patients is that a 70 to 90 grams carbohydrate diet is feasible long-term alternative in the treatment of type 1 diabetes and leads to improved glycemic control. So this is from Nielsen. And this is the same study, but this time they look at adherence. So again, type 1 diabetic, the author is still Nielsen, but this is a clinical audit. They look at long-term improvement and adherence. So the background is that looking at adherence of the patient. So they have not studied this before, and so they want to assess adherence over 4 years. In such a group, the present audit was done retrospectively by record analysis of individuals who have attended an educational course. And so adherence was assessed by the A1C changes as well as the individual's own reports. So the findings, so you have 48 persons, and then the mean A1C, and then you have 25 non-adherent persons, and you have 23 adherent persons. So the conclusion is that attending an educational course on carbohydrate reduction and corresponding insulin reduction in type 1 diabetes gave lasting improvement. About half of the individuals adhered to the program after 4 years, which is very good. And the method may be useful in informed and motivated persons with type 1 diabetes. The number needed to treat to have a lasting effect in one was 2. So very, very significant and very dramatic. We move on to other studies. In this study, they have, again, a low carbohydrate, high fat diet, and they have noted their remission in 3 patients with type 1 diabetes. So this was published November 2020. So this was first patient diagnosed with a condition, and he was 36 years old. He had no medical history. He was a non-smoker, and then upon diagnosis, he began insulin, and then he decided to have a low-carb, high-fat diet to just 50 grams a day. He was able to stop using insulin completely within 15 days. Another patient has a similar experience, and she was able to discontinue insulin. Insulin was only used once following one infectious episode. The third patient was diagnosed at 38, so low-carb diet. Insulin was no longer needed 2 weeks after that low-carb diet, and insulin therapy was once again required, but at low doses at around 16 units per day after 18 months. But the A1C remained very well controlled on the low-carb, high-fat diet with insulin. So to conclude, so with this low-carb, high-fat diet, it results in optimal glycemic control. There was low frequency of hypoglycemia. The effects on lipids were variable. And if this low-carb, high-fat diet, if introduced promptly, could preserve your beta cell function in patients with residual insulin secretion at diagnosis. So what does low-carb diets do? It prevents sharp spikes in your blood sugar. It also reduces your severe hypoglycemia. It can help body weight. It can also help prevent diabetes complications, as well as making diabetes easier to manage. It can also reduce your A1C and can reduce tiredness throughout the day, as well as less hunger between meals and improvement in clarity of thought. And lastly, it can also help in skin complexion. So how low is low? So it depends on you, okay? So we have different needs, you have different lifestyle. You may continue eating starchy food, but you may eat it at smaller quantities. You may decide on 100 to 150 grams of carbohydrate, or if you really want to cut your starch food, then you may aim for a carbohydrate intake of under 50 grams per day. But they advise that if you start with a low carb diet, you have to lower your carbohydrate intake gradually to minimize the risk of hypoglycemia. Okay, we move on to type 1.5 diabetes or pre-diabetes. So how does lifestyle medicine help? So we know that pre-diabetes is a pre-departure before we become diabetic. So this is what's happening here. So you have increased insulin resistance, but you have a decrease in your insulin production. So that's for your pre-diabetes. So that's in the middle part. So this is a study published in 2016, and we're looking at remission of pre-diabetes in obese adults. So this is using your high protein versus your high carbohydrate diet. So this is a randomized control trial by Stentz et al. So the objective is making patients who are pre-diabetic to become normal. And so we look at remission, and this is using your high protein versus your high carbohydrate diet, and looking at metabolic parameters, your lean body fat mass, and this is done 6 months of dietary intervention. So this is a randomized controlled trial involving 24 men and women who has pre-diabetes. So you have one arm, your high protein, that's 30% protein, 30% fat, and 40% carbohydrate. For your high carb, you have 15% protein, 30% fat, and 55% carbohydrate. And then you have your feeding for 6 months. So all meals are provided. You have daily food menus with weekly pickup and food measurements. And then what is measured at baseline and after 6 months are your oral glucose tolerance and meal tolerance tests, your glucose and insulin measurements, and your dual energy X-rays absorptiometry scans. So these are done, and the results showed that the high protein arm, 100% of the subjects had remission of their pre-diabetes, whereas in the high carb arm, only 33.3% of the subjects had remission. So very, very much lower than your high protein diet. And your high protein diet specifically improved in a significant level your insulin sensitivity, your cardiovascular risk factors, inflammatory cytokines, inflammatory oxidative stress, increased percent lean body mass. So to conclude, this is the first dietary intervention feeding study. So it reports 100% remission of prediabetes with a high protein diet. You also have significant improvement in your metabolic parameters and anti-inflammatory effects. So this is, again, another study. This time, you're looking at mechanistic endpoints. You're looking at incretins and cardiovascular risk factors. So again, this is using your high protein diet. So this was published April 2021. So this is by Stentz et al. And the background is that your high protein diet improved metabolic outcomes. So this time you have two arms, your high protein and your high carbohydrate arm. But you're now looking at endpoints like your GLP-1 and GIP, your hunger hormone, your ghrelin, and BNP. And they hypothesized that this high protein diet induced more pronounced release of glucose-lowering hormones, suppress your hunger, and improve cardiac function. So in this study, you have 24 obese men and women with prediabetes. So two arms, the high protein and the high carbohydrate, and then the diet for 6 months, and then all these exams were done. So looking at all these other factors. So the results showed that patients on high protein diet had 100% remission of prediabetes, and your high protein diet subjects have greater increase in your incretin, like your GLP-1 and your GIP. And what is also important is that you have a greater decrease in your OGTT ghrelin and your BNP. So these are your hunger hormones. So to conclude, your HP or your high protein diet increases your GLP and GIP, and this may be the effect would be improved in insulin sensitivity and beta cell function. Also, your hunger hormones are also affected such that it reduces hunger more effectively. Your BNP, your CVRF, your metabolic parameters, and oxidative stress are also improved in your high protein diet. So we move on to type 2 diabetes. So we know for a fact that type 2 diabetes is the most common, and this is your adult onset, and this is the ineffective use of insulin. So this is looking at the problem with type 2 diabetes. So islet function was 50% of normal at the time of diagnosis. So the question I want to throw is, can diabetes type 2 be prevented, reversed, or be in remission? So this is the story of Julie Taylor, who was diagnosed to have type 2 diabetes at 52. She was sluggish and tired all the time. Her GP enrolled her in the NHS weight management program to help her lose weight. And what is dramatic is that I was told, she said, I had put my diabetes into remission after about 10 weeks. I was so happy that I started dancing around the room. I think if that happens to our diabetic patients, we, the doctors, should also be dancing in the room. So that's 2019. So what is diabetes remission? So it is defined as blood sugar levels in type 2 diabetic patients that are healthy without needing to take any medication. In type 1 diabetes, this is a bit tricky and quite difficult, but we have studies going on. Some would do islet transplantation for this type 1 diabetic patient. Remission is defined by the Diabetes UK and the American Diabetes Association, as well as the European Association for the Study of Diabetes, as an A1C that remains below 6.5% for at least 6 months. Some people would call this reversal, but what is a better term is remission, because diabetes can come back. Remission can feel like a fairy tale, but this is something that can happen to real people. The magic is in what you do. So this is what we call the twin cycle hypothesis of the etiology of type 2 diabetes. Twin cycle because you have the liver and you have the pancreas. And so if you have a positive calorie balance, that is, you're eating a lot, and then you have insulin resistance, then there would be accumulation of fat in the liver. And then later on, it would also be deposited in the pancreas. So when these fats are deposited in the pancreas, it destroys the pancreas in a way that it impairs insulin producing beta cells. And so what happened here is that there would be an increase in the blood sugar of our patient. According to Matthew Riddle, he is the chair in Diabetes Remission Consensus, that diabetes remission is defined as a return of A1C to less than 6.5% that may occur spontaneously or following an intervention, and it persists for at least 3 months in the absence of pharmacotherapy. Another, the direct diabetes remission trial, defined diabetes remission as A1C below 6.5%, and there's discontinuation of medications for at least 2 months. Achieving your glycemia below the diabetic range in the absence of active pharmacologic or surgical therapy is also another definition by Dr. Bruce at the Diabetes Care, ADA, and remission can be partial or complete. So welcome to the DIRECT study. So DIRECT is Diabetes Remission Clinical Trial. So you have this intensive program for weight loss and weight loss maintenance. In a nutshell, this study aims to increase the number of people who can become non-diabetic. So these are type 2 diabetic patients. So these are the outcomes at 24 months. If you look at the DIRECT study, okay, you look at the overview, we can see that there's one arm, the control, which is the best practice guidelines. And you have the other arm, the intervention, where you have structured weight management program, which is called Counterweight Plus. And 28% agreed to participate. So if we look at the study population, it is representative of type 2 diabetes. So equally for sex, and most of the patients are obese, and usually they have diabetes around 3 years. 75% or the two arms have a lot of diabetic medications, and the A1C is comparable. So this is your structured program. So at the start, you have total diet replacement. You withdraw your anti-diabetic and antihypertensive medications. And then for 3 months, you have your total diet replacement. And then you have food reintroduction for 2 months. So this is with your practice nurse or dietitian. And then for the next 24 months, you have weight loss maintenance. So the outcome is a weight loss of more than or equal to 15 kilograms and remission of type 2 diabetes with the level of your A1C. So if you look at this, there is really remission at 12 months, and there's also remission at 24 months compared to control. And what is good here is that the medications are also decreased in the intervention group, as well as the lowering of your A1C in the intervention group. So you ask yourself the question, who achieves remission, okay? And who achieves a durable remission? So remission at 24 months is more likely if you have greater weight loss, and if you have greater weight loss at baseline and at 12 to 24 months. So weight loss is the key here. And remission will not vary with baseline BMI or duration of diabetes. Remission is also slightly more likely with older age and the male sex, but they didn't explain how and why. So to summarize, they have noted in this study that 36% of the intervention participants have sustained remission at 24 months. The A1C is significantly reduced in the intervention group. You have 50% reduction in diabetic medications, and a durable remission of short duration is attainable in primary care setting. So this is your counterweight plus group, and you have your weight loss maintenance. So what do they do in counterweight plus? You have principles integrated from day one of total diet replacement. You have monthly appointments, and they check everything, and then you give the results to your research assistant of the direct study. So you can see here that there is greater weight loss at 0 to 24 months in the intervention group. And the primary outcome, if you look at the more than or equal to 15 kilograms weight loss, a lot of the subjects in the intervention group were able to get that weight loss. And it's 17, okay? And it is statistically significant. You only have 3 patients having more than or equal to 15 kilogram weight loss. And you can see remission with more than 10 kilogram loss. You have a 64% chance of remission. And looking at this, at the green line, you have remission at 12 and 24 months. That's 32%. I think those are very good numbers. And then remission at 12 months, but not 24 months, that's 10%. And no remission at 12 to 24 months, 42%. So you analyze the data, 1/3 of early type 2 diabetic patients achieve remission. 64% if their weight loss is more than or equal to 10 kilograms. But what is critical here is achieving and maintaining weight loss. So weight loss for 24 months remains greater than most lifestyle intervention, despite modest gain. And what we see here is that there is also less adverse events in the intervention group. You also have lowering of your systolic blood pressure. You also have a lowering of your triglyceride, an improvement in the quality of life, and a reduction in your or less serious adverse events in the intervention group. So these are the data, and these are the results. So type 2 DM is not necessarily a lifelong condition. It can be reversible with weight loss, 36% in remission at 24 months, 70% in remission, more than 15 kilograms weight loss. And what is challenging here is maintaining the weight loss. So more than or equal to 10 kilogram weight loss achieved by 1/4 of intervention group. So what is happening, or what should be done here, is that you should have support and relapse management, which is the primary concern. You have fewer serious adverse events in the intervention group, and you have to take note that early remission should be a primary management target for type 2 diabetic patients. we move on to exercise and diabetes. In exercise, you have insulin sensitivity that is increased, and so you are better able to use up any available insulin. At the same time, your muscles contract during activity, so your cells are able to take up glucose and use it for energy, regardless if insulin is available or not. So this is your look ahead study. This is Action for Health in Diabetes. It was done 2014, and we have weight loss that is recommended for overweight or obese patients. So you're looking also at long-term effects of weight loss on cardiovascular disease. So that is the background. And so they look at intensive lifestyle intervention for weight loss if it would decrease cardiovascular morbidity and mortality. So you have 16 study centers in the United States. You have 5,000 plus overweight and obese subjects with diabetes. So they were assigned randomly. You have your intervention group. So you have intensive lifestyle intervention through weight loss, through decreased caloric intake, and increased physical activity. You have also the control group where they receive diabetes support and education. The primary outcome was composite of death from cardiovascular causes, non-fatal MI, and non-fatal stroke, and also hospitalization for angina. So the trial was stopped early because of futility analysis. So it's around 9.6 years. Weight loss was greater, however, in the intervention group, and the results show that intensive lifestyle intervention has greater reduction in your A1C and greater improvement in fitness and all cardiovascular risk factors. So the primary outcome occurred in 403 patients in the intervention group and 418 in the control group, not much difference. So they conclude that intensive lifestyle intervention focusing on weight loss did not reduce the rate of cardiovascular events in overweight or obese adults. So that is why it was stopped earlier than 10 years, only 9.6 years. But what are the pros of thought in this look ahead study, your Action for Health in Diabetes? We can see here that overweight or obese adults with type 2 diabetic can lose weight and maintain modest weight loss during the 10-year period. And the initial mean weight loss in the intervention group was 8.6%. This was followed by weight regain through year 5, and then a gradual decrease in weight, resulting in an average weight loss of 6% at the end of the trial. So this is actually very good numbers. So what could be the explanation for the lack of significance? It may be that the study may have lacked power, or the sustained weight loss. You need more sustained weight loss because the differential weight loss between the two trial groups average only 4%. Another is that there was provision of educational sessions and increased use of statins in the control group. So this could have affected the results. But what are the positive effects and benefits? So you have clinically meaningful improvements in your A1C, and these patients are less likely treated with insulin and more likely to have partial remission of diabetes during the first 4 years of the trial. We also have reduction in urinary incontinence, sleep apnea, and depression, and improvement in the quality of life, physical functioning, and mobility. And what is good here is that it prevents or delays the development of type 2 diabetes. So that's the look ahead trial. Okay, so if it has no effect on cardiovascular morbidity and mortality, maybe all those reasons. But there's another study by Hayashino et al. This was published 2013. This is the effect of exercise on mechanistic endpoints like your CRP, your inflammatory cytokine, and adipokine in type 2 diabetic patients. So this is a randomized controlled trial. So you're looking at your CRP, your cytokines, your adipokines, and this causes atherosclerosis, insulin resistance, and the development of complications in type 2 diabetic patients. So there's a systematic review, and then you're looking at inflammatory markers, the cytokines, and adipokines. So these are the databases, and then the studies were selected. So they look at fixed or random effect models, and you have your meta-regression analysis. So the results show that you have 824 patients that was included in the meta-analysis, and they have noted that exercise was associated with significant decrease in your CRP and interleukin. So these are your inflammatory factors. Your exercise did not alter adiponectin or resistin levels. Your aerobic program is associated with significant change in leptin. And your interleukin-6 exercise was more effective if it is longer and with larger number of sessions. So there is an effect in your interleukin if the exercise is longer. So the conclusion of the study says that exercise decreases your inflammatory cytokine in type 2 diabetic patients, and it can have therapeutic option for improving abnormalities in inflammation levels in this set of patients. And lastly, we have the Finnish Diabetes Prevention Study done December 2013, and this is a randomized controlled trial, lasted for 10 years. And so we have 522 participants, and the objective is looking at lifestyle intervention, as well as changes in the diet and exercise behavior, and the effect of the intervention on glucose and lipid metabolism. The control group received general dietary and exercise advice and annual physician's examination. In the intervention group, you have additional individualized dietary counseling from a nutritionist, and you have circuit type resistance training sessions and advice to increase overall physical activity. So the intervention was the most intensive during the first year. This is followed by the maintenance period. So the intervention goals were reduce body weight, reduce dietary and saturated fat, and increase physical activity and dietary fiber. So the results show that the intervention group, the exercise one, or the intensive group have significantly greater improvement in each intervention goal, and you have weight reduction of around 4.5 and 3.5 kilograms in the intervention compared to just 1 and 0.9 kilograms in the control group. And measures of glycemia and lipemia also improved in the intervention group. So to conclude, intensive lifestyle intervention produced long-term beneficial changes in diet, physical activity, clinical and biochemical parameters, and reduced diabetes risk. So this type of intervention is feasible to prevent type 2 diabetes. So to summarize, we know for a fact that medical nutrition therapy in type 1 diabetes improve A1C levels, general well-being, and treatment satisfaction. And a 70 to 90 grams carbohydrate diet is very feasible in the treatment of type 1 diabetes, and it leads to improved glycemic control. What is important is that when you attend an educational course on dietary reduction and insulin reduction in type 1 diabetic patients, this will give lasting improvement. Your high protein diet is the first dietary intervention with 100% remission of prediabetes. There was also improvement in metabolic parameters and anti-inflammatory effects. Your high protein diet increases your GLP-1 and your GIP incretins. It improves insulin sensitivity and beta cell function and reduces hunger. The intensive lifestyle intervention produced long-term beneficial changes in diet, physical activity, and clinical and biochemical parameters, and reduced diabetes risk. And lastly, your type 2 DM is not necessarily a lifelong condition. It is reversible with weight loss through diet and exercise enhances insulin sensitivity. Your intensive lifestyle intervention improves your A1C. It also causes partial remission of diabetes during the first 4 years. It also shows improvement in quality of life, physical functioning, and mobility. Exercise prevents or delays development of type 2 diabetes. It also decreases your inflammatory cytokines, and it is an option for improving abnormalities in inflammation levels in patients with diabetes. So lifestyle therapy for diabetes type 1, 1.5, and 2, to summarize it all, it works. So I think I have convinced you that we have to educate our patients to do lifestyle therapy for them to see hope in a situation that is never hopeless. So I do believe we are all born with the ability to change someone's life. Please don't waste it. Change the lives of your patients. So thank you very much. So thank you very much for the time And I hope I have convinced you enough that lifestyle medicine is really the way to go in all these lifestyle diseases. So thank you very much, and I would appreciate any clarification, concern, or questions. We will learn from each other. So thank you very much. Stay safe. God bless.
Lifestyle medicine for COVID-19 and NCD care, a wake-up call.
Our vision is to be distinguished as a fast-growing Filipino pharmaceutical company advancing a legacy that provides reliable, high-quality health and wellness that are responsive and relevant to the changing needs of patients and customers. Blumea balsamifera sambong leaf. Relief Forte. The longer, the better. Relief Forte. Relief for urinary stones. Acetylcysteine. Acetimax. Dissolves mucus to the max. The number one 50 milligram sildenafil brand in the Philippines and the most prescribed sildenafil citrate in the market. Zilden, now on its 10th year. Manage your BP. Protect your kidney. Like a pro. Irbipro, the certified safe irbesartan. The only prescription-grade L-carnitine available today. Enhance your heart score with Carnicor. ACE inhibitor enalapril is recommended by the ESC for heart failure with reduced ejection fraction. Enalapril maleate high pace. Keep their hearts at pace. Eliminate potassium loss worries during diuresis. The only furosemide with potassium. Diamide K, ang furosemide na may K. Pregabalin Pregasafe with AAA effect, analgesic, anti-epileptic, and anxiolytic. Pregasafe, no pain, all gain. Fluocinolone acetonide, Aplocin, the reliable topical corticosteroid for acute and chronic dermatosis. Aplocin. Brought to you by Pascual Pharmacorp, building a legacy of care.